मेरे ख्याल में स्टार्ट कर लें प्रेजेंटेशन.
Right, sir. Right, sir. We are starting, sir. Yeah. Assalamu alaikum, sir. My name is Dr. Kamran Hayat. I am a second-year fellow in neonatology in Indus Hospital. I hope you can all hear me, sir.
Yes. Can you please share your video, if possible?
Sir, sharing the video is possible, but unfortunately, it is going to distort the sound. I fear, and that
Okay.
That's just sir. Right. लेकिन क्यों आगे क्यों नहीं जा रहा है? So today I'm going to present a case. It's an interesting case, and I hope that it will help us in sorting out few things as well. Basically, we received a 5-day-old male baby named Huzaifa, a resident of D.I. Khan, presented to us in OPD on 5th day of life with complaints of yellow discoloration of skin. The baby was, there were complaints of lethargy and decreased oral intake as well. The father was the historian, and according to him, the baby started to have this yellowish discoloration on the very first day, and it was progressively increasing in intensity. So as far as the antenatal history is concerned, the baby was born to gravitatory para-2 mother. Both the parents were related. They were the parents were cousins, first cousins. There is significant history of 2 intrauterine deaths as well. So one was male and one was female. The death was at full term, and according to the father, the male was all swollen and edematous, from which we basically gathered that he might be a hydrops vitalis baby. There is no history of any significant maternal inlet. There were regular antenatal visits done. The mother blood group is A positive, and there was no antenatal scan done, sir. The baby was born by C-section at 37 weeks of gestation. When I asked about the cause of the cesarean, the father said that they were told that the baby is breech. Male baby was delivered with immediate cry at birth and shifted with the mother. The feed was started within an hour of birth, and the baby passed meconium within 6 hours. The father stated that the baby started to develop jaundice on the very first day. It was increasing in intensity. As far as the family history is concerned, the baby was born to consanguineous parents. The father blood group was also A positive. Another a specific point in the history was there was history of 5 intrauterine deaths in maternal uncle's family, and this was the only alive issue of this couple, sir. Sir, on examination, the baby was deeply jaundiced. The anthropometric measures revealed that the weight, length, and head circumference were all less than 50th centile. The general physical examination of the baby revealed that there were no dysmorphic features in the baby. The baby was deeply jaundiced, lethargic. Eye examination was unremarkable. Oral cavity examination was normal. There was no cleft lip or cleft palate. The back was also normal. The baby had male genitalia. The testes were also palpable, sir. The systemic examination revealed that the abdomen was soft, non-tender, non-distended. Liver was palpable. It was firm in consistency. The total span was 8 centimeters. The margins were regular and smooth surface, sir. The spleen was also palpable. It was 4 centimeters. It was also firm in consistency, sir. There was no rash on the body. The cardiovascular examination was also unremarkable. The neonatal reflexes of the baby were sluggish. The suck was poor, and the motor reflex was weak. So we started with the initial investigations. We sent the complete blood count of the baby, which revealed that baby had a hemoglobin of 5.7. The platelet count was 45, and there was a peripheral film was also sent, which showed normocytic picture with few spirocytes, and The MCH was 32. MCHC was 30, and MCV was 108.6. The TLC was the corrected TLC was 37,000 with 45,000 platelets. So this is basically a follow-up CBC which we have done, and I'll show you this later on as well. But let's move on to the other slide. This is the reticulocyte count. The reticulocyte count on arrival was 30%. So the baby was having reticulocytosis, and the reticulocyte count on arrival was 30%. The CRP was positive. It remained positive throughout the admission. The baby was discharged, later came back, and again, the baby was having a positive CRP. The direct Coombs was negative. So twice the direct Coombs test was done, and it was negative. This is the liver function test of the baby. So initially, the baby was having normal liver functions, like the gamma glutamyl transferase was initially normal. ALT was also normal, but it started to deteriorate, and it deranged progressively over the period of time. The gamma glutamyl transferase was initially 39, but then after a couple of weeks, came 72, 195, and the latest was done on 30th of January, which is 438. The bilirubin, obviously, sir, was at presentation, it was 32, but the direct component of the bilirubin was 17, sir. And so the ALT was also initially normal, but later it started to deteriorate as well. So this is the stool color of the baby, which shows that the stools were not ecolic either. It was normal in consistency and normal stools with normal color. So ultrasound abdomen was advised, which showed that the liver was enlarged with smooth margins. The total size was 80 millimeter with normal parenchyma. This was the diameter of the common bile duct and portal vein, that was 3 millimeter. Spleen was enlarged with the size of 55 millimeter, and there was thick walled gallbladder with a thickness of 1.5 millimeter, and there was no further clue that could help us on ultrasonography of the abdomen as well. Serum electrolytes of the baby were normal throughout, so there was no abnormality detected in serum electrolytes as well. We went for urine complete examination, which was also normal. The malaria ICT, which was advised in the baby, that turned out to be negative as well. We also did malaria ICT in the mother, that was also negative, sir. We did thyroid function test, and TSH was obviously normal. Then again, on 12th of January, we repeated it, which was in the lower border limit, sir. We went for G6PD quantitative levels, which were in the normal limit. The level came out to be 10.98 with a reference of 7.9 to 16.3, sir. So as the baby and the blood group of the baby, the mother and the father was A positive, and we thought of the possibility that the baby might be having some minor blood group incompatibility. So after discussing it with a hematologist in our hospital, she advised us to go for maternal antibodies for minor blood group. We sent them to Aga Khan, which also came to be negative, sir. Urine for reducing substances was sent, which was also negative, sir. The question here arises that what do you think is the cause of hemolysis in this baby? And what do you think is the cause of jaundice in this baby, sir?
So if anyone want to respond, then please raise your hand. You can unmute yourself. Dr. Furqan, you can respond if you want. Any volunteer?
Sir, I would like to summarize the case again so that you people can get an idea, sir. A 5-day-old baby has presented to us who is born to consanguineous parents. The blood group of both mother, father, and the baby is A positive, sir. The baby presented to us with deep jaundice, and that started on the first day of life. that was progressively increasing in nature. This is the first alive issue of the couple, and it was delivered by C-section at full term. The cause of delivery was breech presentation. There is significant history of 2 intrauterine deaths at full term. One was male and one was female. The male was hydrops vitalis. The maternal uncle, the Mamu, has history of 5 intrauterine deaths in his wife as well. And as far as the laboratory investigations are concerned, the baby was having reticulocytosis of 30% retics. The HB on presentation was 5.7 with 45,000 platelet count and 37,000 TLC counts. MCHC was 30 and MCV was 108. We moved further, and the liver function tests initially were normal, which started to deteriorate over a period of time. The latest gamma glutamyl transferase were 438. ALT was also deranged. DAT direct Coombs test was negative twice, and thyroid profile was also normal, sir. The minor antibody blood group testing in the mother proved out to be negative. The maternal and the malarial ICT in both the mother and the baby were also negative, sir. So the question is, sir, what do you think is the cause of hemolysis in this baby, and what do you think is the cause of jaundice in this baby, sir?
Dr. Kamal, Assalamualaikum. डॉक्टर सईद है। डॉक्टर कमरान, मदर की जो टॉर्च की हिस्ट्री है वो वर्कअप करवाया फर्स्ट टाइम? व्हाट अबाउट टॉर्च वर्कअप ऑफ द मदर, टॉर्च प्रोफाइल?
So torch profile, we asked the father to bring the mother, but actually they are living in a remote area. So we have asked him to bring the mother to us so that we can have a detailed discussion, and we can go for a torch screening of the mother as well, sir. But
right.
for us, sir, clinically,
here is
sir, clinically we could not find any features of torch infections in the babies. I mean, there was no history of any microcapillary. The cardiac examination was unremarkable. The eye examination was also unremarkable. So we went for ophthalmological examination of the baby as well, but there was no obvious clue for chorioretinitis in the baby. And the eye examination was also unremarkable. So was the CVS examination was also unremarkable, sir. Yes, and the baby was appropriate for growth as well. So the growth parameters, although below 50th percentile, but they were all appropriate for the Yes, sir.
Did anybody read the blood film?
Yes, sir. Yes, sir. Yes, sir.
So what is the result of that blood film?
Sir, the blood picture initially, sir, was discussed with hematologist, and she was also very keen and participated with us. And twice the peripheral film was sent. It showed few spherocytes with normochromic normocytic anemia, but there was no further clue in the peripheral film, sir.
So because that's why I asked.
MCHC was 30, it was then 32 and 34. Yes, sir.
Because
it was normal.
Yeah, hemolytic jaundice can go with the hereditary spherocytosis, you all know. So that's why I asked. Yeah.
Yes, you're right. But yes, it's out of the possibility of hereditary spherocytosis as well, sir. But the repeated MCHC in the complete blood count was not sportive, sir. It remained below 36, and it was 34 once, 32 another time, and 30 another time. So it was not sporting the diagnosis of hereditary spherocytosis, sir.
Okay. All right, Dr. Kama, here as far as HS is concerned, you are right, because 35.5 is, I think, cut off to diagnose the hereditary spherocytosis on the peripheral in CBC. But my question is कि ये जो आपने करवाया था एंटीबॉडी स्क्रीनिंग करवाई थी, तो एक है एंटीबॉडी स्क्रीनिंग, एक उसके बाद होता है फुल पैनल, because sometimes क्योंकि in this scenario baby having the hemolytic anemia as well as jaundice. So मेरा ये पॉइंट है कि वो जो एंटीबॉडी स्क्रीनिंग जो करवाई थी, क्या वो फुल पैनल था या सिंपल एंटीबॉडी स्टार्टिंग में स्क्रीनिंग, क्योंकि उसमें सारी जो है एंटीजेंस वो नहीं करते, जहाँ तक मतलब मुझे इस चीज का आइडिया है, तो इस पे थोड़ा सा आप फाइनली कमेंट कर दें।
सर इसमें जो है ना, वी डिस्कस्ड विद आगा खान इन इस्लामाबाद, सर, क्योंकि वो DI खान से थे, तो उनको इस्लामाबाद नजदीक पड़ रहा था, तो वहाँ पे गए. I also called them और उनको मैंने बताया, तो they offered me a complete panel of the antibodies. So, sir, I'll share the report with you as well. I'll try to share it on the academic group. Or, but it was a complete panel, sir, which turned out to be negative, sir.
Another, somebody look into the causes of anemia in this patient. अब पता नहीं उतनी फैसिलिटी है कि नहीं. Hello.
Sorry. Yes, sir.
Yeah, causes of other causes of anemia.
सर अदर कॉजेज की अगर हम देखेंगे तो इन केस अगर न्यूनेटल एज में है तो उसमें अगेन यही कॉमन चीज़ें कंजेनिटल ल्यूकीमिया या फिर कंजेनिटल इन्फेक्शंस या फिर जो है अकॉर्डिंग टू कूम टेस्ट के थ्रू हम प्रोसीड करते हैं. तो अगेन फिर उसके बाद एंजाइम्स कुछ होते हैं जो कि मेरे ख्याल में यहाँ पे पाकिस्तान में.
Sir, we thought of sir, in our mind we had a complete discussion with our head of department, and we thought of either it is because of some RBC's enzymatic defects, and we also thought of the possibility of some membrane defects as well, and then later on we thought that the patient might be having some sort of thalassemia. We also discussed the case with a hematologist, and she was of the opinion that it is quite better to send the HP electrophoresis of the mother, father, and the baby. So we did that, and HP electrophoresis of the father and the baby is awaited, but HP electrophoresis of the mother was normal, sir. And as far as the enzymatic defects are concerned, we do we did send glucose 6-phosphate dehydrogenase twice, but it was normal in
it
the
was
normal.
Negative.
Yes,
because sickle cell is also be the possibility. I know it is not that common there in Pakistan, but just see what hemoglobin electrophoresis showed.
Right, sir. It is being awaited, sir. Unfortunately, because of the fog, the flights were delayed. So we did this the 10 days back, sir. The sample was kept in our hospital and it was sent 4 days back, sir. We are looking forward to the result of HP electrophoresis, sir. Once it arrives, I'll definitely share, sir.
But here is my another some query, Dr. Kamran. Yes, here is a both scenario. No? One is hemolysis is there, and second thing is where we fit the conjugated hyperbilirubinemia. Although it's a significantly raised. अगर हम बात एक ही तरफ अगर सोचेंगे हम हीमोलाइटिक वाली लाइन पे, तो जॉन्डिस को हम कहाँ फिट करेंगे जो कि कंजुगेटेड जॉन्डिस है. तो क्या साइमल्टेनियसली कोई ऐसा नहीं है कि मतलब ऐसी कोई चीज जहाँ पे जो है दोनों चीजें अगर लिवर भी इन्वॉल्व है और साथ में जो है हमारी हेमोलाइसिस भी हो रही है.
सर इसमें ये है कि सर the only possibility that had in our mind was if you see again the ultrasound, sir, it showed that there was biliary sludging, there was accumulation of bile in the gallbladder, sir. So we do think that we still have a strong suspicion of insufficient bile syndrome in our minds, because excessive hemolysis along with firm hepatosplenomegaly shows that there was some sort of congenital hemolysis that was going on, and the development of hyperbilirubinemia within few hours of birth, that's too conjugated, reveals that there is some sort of issue that was present congenitally, and yes, initially the enzymes were also normal. So we must keep in mind that the ALT gamma glutamyl transferase remained normal for the first 12 days, which later started to deteriorate, and currently now are at the level of 438 gamma glutamyl transferase and 115 is ALT, sir. Yes, and the PT was normal, sir. Yes, the PT was normal, sir. The prothrombin time was also normal, sir. Sir. Sir?
Please, sir. Hello. Hello.
जी जी आपकी आवाज आ रही है. किसी और को कुछ कमेंट ऐड करना चाहे डायग्नोसिस में?
Sir, this was our course, the baby's course during hospital stay. So the baby was admitted. Immediately exchange transfusion was planned, which was done. But before that, we sent all the investigations that were required to us. and the exchange transfusion was followed by packed cell transfusions as well. So the baby was placed on first-line antibiotics, and the baby remained with us for 17 days, and later the baby was discharged on micronutrients and multivitamins, along with ursodeoxycholic acid at a dose of 20 milligram per kg. Fat-soluble vitamins A, D, E, K were also advised. Vitamin A was given at a dose of 5,000 international units, along with D, which was given 3 times of the recommended daily allowance. Ursodeoxycholic acid was also sent, sir. The baby was readmitted few days back with pneumonia, and the baby was having hepatosplenomegaly, but the bilirubin count was improving, sir. It was initially at 32. After exchange transfusion, it was 19. But then when the baby was discharged on total bilirubin of 20. But when the baby came back, there was some sort of response to ursodeoxycholic acid, and the bilirubin level at the time of readmission was 12, sir. So this is what we have done. We have again discharged the baby, sir. And the plan is to add steroids, to give a trial of steroids, and then we are going to plan for bone marrow biopsy. Steroid is basically we are going to go for steroids in order to minimize and reduce the inflammation if there is any inflammation, sir. It was discussed with our senior in the academic group, sir. We discussed this case with Professor Khalid Haq Saab, and he advised us to start the steroids, sir, and then we are going to plan for bone marrow biopsy, sir. We did a multidisciplinary approach in these patients. We did consultation with hematologists. We discussed the case with hematologist. She was basically of the opinion, and she told us to go for minor antibodies for minor blood group antibodies, which we already did, and it turned out to be negative. She also asked us to send the HB electrophoresis of the parents and the child, which was also sent. Ophthalmologist review was taken. There was normal eye examination. The fundus appeared normal as well. There was no cataract or chororetinitis seen, sir. We have discussed the case with pediatric gastroenterologist as well. He was of the opinion that we should send CMV PCR qualitative level, which has already been sent. And he was also of the opinion that we should keep insufficient bile syndrome in our diagnosis as well, sir. So this is what we have done up till now. And but the case still falls in a gray area. We are totally not sure about the diagnosis. And I would like to have your suggestions on your part. So what do you think is the possibility of the diagnosis in this baby, and how further can we move in this baby, sir?
अस्सलाम वालेकुम भाई, एक क्वेश्चन था कि उसकी HP बेबी की बाद में ठीक रही है कि वो भी ड्रॉप हुई है बाद में?
Yes, sir. The HP has dropped, sir. Initially, at presentation, the HP was 5.7. After transfusion,
यदि आपने पैक सेल दे दिए ना, तो उसके बाद क्या दोबारा भी ड्रॉप हुआ?
Yes, sir. पैक सेल सर जब दिए तो it was 19, sir. सर मैं आपको दिखाता हूँ सर. ये सर, this is follow-up CBC, sir. HP में आप सर देखें, it was initially जब हमने उसको ट्रांसफर किया तो it was 19.3. And then it has again started to decline and decrease gradually. So 15.3 on 19th of December, 12.9 on 5th of January, and 11 and on 11th of January it was 12.2, sir.
So I think definitely it is going towards hemolysis, because as you can see, the hemoglobin is dropping.
Yes,
and the other thing is that my question is that why we exchange transfusion did in this baby?
The child was encephalopathic.
Sir, initially at presentation the child was encephalopathic. Obviously, sir, the border turned out to the levels turned out to be 32, which was total bilirubin level.
But direct is 20 out of that. If I remember, if you go to the direct,
yes,
at
yes,
that time,
22.
I think 17.
17. So it will not help in that regard. You got my point?
Sir, yes, yes.
The child got jaundice from the first day of life. and they gradually worsens. And the child was able to take the feed from the very first day, and gradually he started to lose to take the feed, and she becomes encephalopathic within the next couple of days, 3 or 4 days, and the child reached out to us at 5th day of life. So keeping the possibility of high turnover with the child was unable to take the feed, and his was anemia along with encephalopathy and along with hepatobilirubinemia. That takes us to take a chance to take the child from out of the encephalopathy. The change is something else that can reduce the bilirubin. The child has responded in the well that the child after 5 to 7 days of therapy to start taking food from orally and improve. You say that the platelet count also improves after the exchange transfusion, and the TLC count will also improve.
अच्छा भाई, सॉरी मैं एक और क्वेश्चन जरा पूछ लूं. अच्छा, जब आपने स्टीरॉइड दिए हैं तो
नहीं स्टीरॉइड अभी नहीं दिए सर.
We think the possibility to clear the extrahepatic tract with the use of steroid. That steroid reduces the intrahepatic cholestasis as well extrahepatic infiltrative bile syndrome, along with it reduces the inflammation. This is the suggestion given to us by Dr. Khalid. We have not added the steroid.
मैं ये सोच रहा था कि अगर कोई ऑटोइम्यून प्रोसेस है जिससे हेमोलिसिस हो रही है जो कि हमारी लैब्स में नहीं आई, तो कुड बी पॉसिबल कि जो स्टीरॉइड देने से अगर तो रिस्पॉन्ड आता है, दैट कुड बी पॉसिबिलिटी. लेकिन अगर आपने नहीं दिए तो डेफिनेटली ये तो अच्छा ही किया है, पहले कंफर्म करके देने पड़ेंगे वो, बेबी के न्यूरॉन्स पे बड़ा इनका इफेक्ट हुआ.
That was also negative, and the same blood group of the parents and the baby also suggests that it is not immune related process. No?
But sir, immune process, I think we cannot rule out in this baby on the basis of the direct home test, because it comes positive in 3 to 4% of the baby. So it's not 100%.
100% तो नहीं है.
नहीं सर, the sensitivity of direct home is usually 30%, so we know that the 30%
3 to 4%.
अच्छा, वो बाद में भी आपने तो 2-3 दफा चेंज करवाया ना, डेट तो दोनों दफा नेगेटिव आया.
यस सर.
अच्छा, वो मैं हेड्रॉप्स फेटालिस की तरफ जा रहा हूँ ना, मैं सोच रहा हूँ कि पहले हेड्रॉप्स फेटालिस में एक फैमिली में डेथ भी है.
यस सर, एक सर इंट्रायूटेरस सर इसी बच्चे के इसी कपल का सर देयर इज अ डेथ ऑफ one intrauterine death who was male, and according to the father the baby was all edematous, or मतलब he told me that the baby was all swollen sir. So basically we presumed that might be a case of hydrops fetalis sir. उसके अलावा सर इसके जो मामू जो है, इस बच्चे के जो मामू है उसकी फैमिली के अंदर सर 5 इंट्रायूटेराइन डेथ्स हैं, एंड द फादर वाज अनअवेयर ऑफ द कॉज सर. उसकी फिर उसको कॉज नहीं पता थी सर. वो भी फुल टर्म डेथ्स हैं सर, ऑल ऑफ द सडन.
इस सूरत में तो यार लगता तो ऐसे ही है कि जैसे ऑटोइम्यून की तरफ ज्यादा इनका कोई प्रोसेस चल रहा है, पता नहीं अब. लेकिन इसी फैमिली में अगर देखा जाए तो जैसे हेमोलिसिस हो रही है और साथ हेड्रॉप्स फेटालिस भी है, तो स्टीरॉइड के लिए डिस्कस किया जा सकता है, नो डाउट. इसमें 2 बेनिफिट्स तो होंगे ना, एक तो इम्यूनिटी कम हो जाएगी और यानी कि ऑटोइम्यून प्रोसेस में फायदा होगा, और दूसरा अगर जो आपकी जॉन्डिस लेवल है वो भी इससे नीचे होगा, बेटर हो जाएगा. क्लियरेंस अच्छी हो जाएगी.
राइट सर.
But this is my only.
Again, here is my question again. If we thinking for autoimmune hemolytic anemia, yes, it's true, could be. But where we fit the direct hyperbilirubinemia?
Infiltrated bile syndrome, once the child, the basic process will be the unconjugated hyperbilirubinemia. Once the conjugate biliary becomes, once it chokes the biliary tract, it can eventually lead to infiltrated bile syndrome, because the initial enzymes levels in normal ALT shows that the liver parenchyma is normal. PT was also normal. That shows that liver is healthy. The only process is the encephalopathy that leads the child was remain encephalopathy for a couple of days or hours. That leads to the possibility of the child gets into the infiltrated bile syndrome.
So can we think for the thalassemia in case like 5th day of life, encephalopathy, direct hyperbili is increased?
देखिए उसमें फिर हमारे पास how we can explain hydrops ना. in the family, only with the tyrosinemia. And the child is improving. The child encephalopathy is better. He is taking feed
oral
feed,
feed,
and
sir,
is
currently.
thriving, and is getting weight. No?
So currently the baby is on oral feed, sir. He is currently, although the jaundice is persisting, but the intensity has decreased. The hepatosplenomegaly still persists, sir, but the baby is neurologically the baby is well, and he's very responsive, and he's tolerating feed, he's sucking good, and he has a good motor reflex as well. Although yes, the baby is out of encephalopathic behavior.
Can we think of other viral infection like EBV, parvo, which can lead to this situation? Infection may affect mother in the last in the perinatal period.
अच्छा एक और
जी सर
जी एक और सजेशन ये है
that 30% reticulocyte count showed that it is a hemolytic process rather than the bone marrow suppression.
सर इसमें मुझे EBV जो है सर वो does it lead to reticulocytosis, sir?
I have no idea about the reticulocytosis, but it can affect bone marrow suppression.
Bone marrow suppression. Epstein-Barr virus causes bone marrow suppression. So it does not lead to reticulocytosis.
And recurrence in the family of the same problem is also ruled out of something
अगर वायरल का देखना है हमने तो MRI ब्रेन बाज बात हेल्पफुल हो सकता है कि उसके जो फाइंडिंग है CMV वगैरह की वो आपको अर्जेंट मिल जाएगी
राइट
यू आर थिंकिंग तो दैट कुड बी अ पॉसिबिलिटी क्योंकि CMV को वैसे मेरे ख्याल पता नहीं आपने कौन से टेस्ट करवाए हैं तो डिफिकल्ट टू कैच हो जाता है बड़ा अर्ली लेकिन ये है कि अगर आप MRI ब्रेन कराएंगे तो उसमें इफ यू फाइंड द फाइंडिंग्स ऑफ टॉर्च के साथ से कोरिलेट कर लेंगे तो दैट कुड बी इजी वे है
राइट सर
But this is not the presentation for CMV.
It is not, definitely not. You're right.
Yeah, I think concentrate on hemolysis as much as possible because this is the only continuous factor in this kid. Yes, all other things are coming and going. Okay, so I don't know it's a real encephalopathy or what, and what are the signs. But right now, if you look, the baby it is in hemolytic, and you said that you chase all the minor blood groups also, which is negative. Am I right?
Yes, you're right, sir. You're right, sir.
Yeah, so the hemolytic disease can give you the direct hyperbilirubinemia. Okay, so now you said that hepatosplenomegaly enlarged. So all go into the favor of these things, which you can find it out easily in hemoglobin electrophoresis.
Yes, HP electrophoresis is done and it is awaited, sir.
Sure.
Let's hope we get a clue from there as well. And sir, I would like to ask, do you think that it's the case of insufficient bile syndrome? Because obviously excessive hemolysis had led to choking of the bile canaliculi, and that has later led to the deterioration of gamma-glutamyl transferase and ALT as well. So we should, do you think that we should keep the diagnosis of insufficient bile syndrome at the top, sir?
But insufficient bile syndrome, then why the hemolysis is continue right now? You see the pattern of reticulocyte, it is still high.
Sir, initially the reticulocytes were 30%, but although the HP has started to decline, the reticulocyte count are now at 1 to 2%, sir.
Okay, now is 1 to 2%. Okay.
Yes.
Yeah.
Yes, sir.
And what about the hemoglobin? How much hemoglobin now?
Hemoglobin is now, it was repeated one week back. It was on 11th of January. The HP was 10.2, sir.
10.2. So, but it is after transfusion.
Yes, it has declined after transfusion. So the transfusion was done on 19th of December. And at that time, the HP was 19 or 18, 19. But now, over the period of time, the HP has declined drastically. Sir, it is 10.2 now.
Yeah. So it can be the possibility, the insipid bile syndrome. I mean, this is also can be the possibility, but then you have to do another few, uh, uh, like a lot of other tests also to see the.
I think you're talking about HIDAS cancer.
Yes.
And
Yes.
for liver biopsy as well, sir, because we discussed this with gastroenterologist and he advised us to wait for the CMV result. He also advised us to wait for HP electrophoresis. Once the HP electrophoresis and CMV results are available, then he said that he'll go for, he will plan to go for HIDAS scan and for liver biopsy as well, sir.
Yeah, that's I think good plan actually.
Yes, sir.
Here
So
is
meanwhile,
another
we're going to continue with orthodeoxycholic acid, sir, and we are going to continue with fat-soluble vitamins as well, sir.
Yeah.
And water.
Here's another one thing I'm thinking. Okay, does alpha thalassemia present in neonatal period with severe anemia, so severe anemia, and as well as hyperbilirubinemia?
Sir,
I think, GG.
basically, I think it does, depending upon the deletion of the change. Sir, the history of hydrops vitalis is a very strong point. The history of intrauterine deaths, more than 5 intrauterine deaths in the same family within the close vicinity. That also is a favoring point, sir. But I think that once there are 3 deletions, then obviously it can present, because we know that the hemoglobin in neonate is alpha and gamma.
Exactly.
Alpha and gamma thalassemia can present in the neonatal age group. That can present non-conjugated hyperbilirubinemia.
Because here the main thing which I confuse, or I try to understand, here is two different processes. One is introduced to the liver, and another is with the reticular endocrine system with the bone marrow. तो ये चीज जो है ना वो मतलब कि कोई एक नहीं है, क्योंकि एक हीमोलाइसिस हो रही है हमारी, और ऑन सेकंड हैंड पे हाइपरबिली जो है हमारा लिवर जो है वो इन्वॉल्व हो रहा है.
सर इसमें देखिए सर, अब इसको हम यूं भी तो ले सकते हैं ना सर. देखिए, द बेबी इज हैविंग severe hemolysis, sir.
Right.
This severe hemolysis is definitely going to go with increase in bilirubin, sir. Or obviously this bilirubin can lead to
indirect bilirubin.
Yes, it can lead to indirect bilirubin, and this indirect bilirubin, can lead to the biliary sludging, sir. It can even lead to formation of bile plug, and that further can lead to direct hyperbilirubinemia. But again, sir, it's just an imagination, and like it's
right. Agree.
Theoretical things, but we are still nowhere with this case, sir.
Well, very interesting case.
Yes, it is, sir. It is very interesting case, sir, and I'm glad that I got the chance to share it with you people.
I think we must ask again, repeat from our hematologist for the antibody screening panel.
Right.
Complete panel, because it possibility है कि हो सकता है कि complete panel की दोबारा बात करें कि it might becomes too positive, because recently कल मैंने एक केस देखा था ओपीडी में यहाँ पे हमारे यहाँ कराची में ही ना, तो एक मदर आई थी. खैर उनका तो वो न्यूबॉर्न पीरियड का वो बच्चा नहीं था, उसके बच्चे की एज जो है वो 2 मंथ थी, तो उसके भी सेम जो हिस्ट्री आप बता रहे हैं डॉक्टर कमरान हमने शेयर किए, उनकी भी सेम समहाउ मतलब वो मिमिक कर रही थी हिस्ट्री, तो इसलिए उनकी वही सेम एंटीबॉडी स्क्रीनिंग वो सारी चीजें जो है वो हुई थी, तो कम्स वो पॉजिटिव उनकी पॉजिटिव थी ना, तो उनकी रेयर एंटीजन थी. दैट्स व्हाई आई एम थिंकिंग कि वी शुड अगेन डिस्कस विद आवर हेमेटोलॉजिस्ट for re-evaluation of the antibodies panel.
Sir. Right.
ये रेड ब्लड सेल्स लगने के बाद ये जरूर पूछ लीजिए कितनी देर बाद हम करवा सकते हैं, क्योंकि अब आपने ब्लड तो दे दिया उसे, तो पॉसिबिलिटी ऑफ बीइंग पॉजिटिव काफी ज्यादा हो जाएगा, लेकिन ये आप पूछ लीजिएगा कितनी देर बाद करवा सकते हैं, तो नो डाउट इट विल बी वेरी हेल्पफुल.
राइट सर.
तो ब्लड देने के बाद मेरे ख्याल काफी देर वेट करना पड़ता है, more than 120 days or something, so then is the chances of getting that to.
Right sir. Anything else, sir, you would like to add? Basically, this is it from my side, sir.
Sir Junaid?
Yeah. One thing only I want to ask about. Somebody wrote for the bone marrow biopsy. Who asked for that and why?
This is from the last day. Dr. Khalid had suggested that initially you have a low platelet count, तो उनका ध्यान में था कि हमें थोड़ा सा extension, हाँ, leukemia की line पर या उनका last suggestion था कि इसके बारे में भी सोचें.
Leukemia is very, I mean, in this condition is, I don't think so, but anyway, the main thing is that एक दफा फिर कोई अगर now if somebody can review the blood film, wait for hemoglobin electrophoresis, and then think about the other test, as GI said.
Yes. This is what we are going to do. Sir.
Yeah.
Although we are thinking to start the steroid once the baby comes to us on follow-up, and at that time we can see
steroid for what? What is in your mind? What the steroid can help? How the steroid can help?
Steroid reduces the inflammation in the liver, as well as it also leads to clearance in the intrahepatic as well as extrahepatic obstruction. If there is any side effect, things can lead to obstruction.
I think that the chances of the side effect of the steroid is much more than that. So just think about it. Steroid, why we are.
This suggestion was also given by Sir Khalid and Haq. I think we will discuss with the gastroenterologist here, and after this consultation, if he thinks, then
we should discuss with the thing. Yeah, that's the only point.
Right.
भाई अगर chronic hemolysis हो रही है और होती रहेगी तो उसमें भी तो स्टीरॉयड का भी रोल है कि नहीं? अगर हम सोच रहे हैं कि hemolysis हो रही है और डेफिनेटली ये ऑटोइम्यून की प्रोसेस से हो रही है, अगर
इम्यून रिलेटेड हेमोलिसिस में तो फायदा देगा, बाकी जो ब्रेन डिफेक्ट्स हैं, आपकी पैथीज हैं, आपके जो एंजाइम डिफेक्ट्स हैं, इट विल नॉट हेल्पिंग इन द रेस्ट ऑफ द केसेस. तो अभी हमारे पास इम्यून रिलेटेड कुछ, अभी हमारे पास कुछ इन हैंड भी तो कुछ भी नहीं है ना
सर. इसमें एक चीज ऐड करना चाहूँगा. इसमें ये है कि अस्सलाम वालेकुम, आई एम डॉक्टर हसान, फेलो न्यूरोलॉजी इन द हॉस्पिटल. जैसे ही हमारे पेशेंट में मैं सजेस्ट करता हूँ कि इसमें हमें एक तो मैटरनल हिस्ट्री लेनी चाहिए SLE के लिए, ऑटोइम्यून डिसऑर्डर, और उनकी एंटीबॉडीज हम स्क्रीनिंग करा सकते हैं, क्योंकि वो भी साइटोपिनियाज और स्किन मैनिफेस्टेशन और जो है ना हिपैटोबिलरी मैनिफेस्टेशन के साथ प्रेजेंट कर सकते हैं. तो एक ये चीज़ हम मजीद फर्दर उसमें कर सकते हैं.
बट SLE वाले जो होते हैं ना, लुपस विद SLE, यस यू आर राइट, बट उनकी जो क्लिनिकल पिक्चर है होती है आफ्टर बर्न न्यूट्रोपिनिया, साथ में LFT डिरेंजमेंट, वो सारी चीज़ें. तो हेमोलाइटिक वाला कंपोनेंट आई थिंक उसमें लेस लाइकली होता है.
फैमिली हिस्ट्री भी है ना, मतलब उसकी
राइट. Here is another question from my side. I think can we use in this baby IVIG instead of steroid, as baby is continuously having the issue of the hemolysis? In spite of transfuse the baby, despite the transfuse IVIG.
I think probably one of the reason of dropping the hemoglobin is that we have taken multiple tests for this child. तो आप देखें तो फिर hemoglobin का drop है, और retics does not show that the continuous hemolysis is still going on because the retics are now about 2 or 3%.
Right, sir.
क्योंकि इस दौरान जो इसको काफी दफा फ्लेबॉटमी हुई है बच्चे की मुख्तलिफ टेस्ट के लिए, तो आप ये देखो 10-12 दफा हमने इसमें कुछ ना कुछ प्रोब करने के लिए या इसको देखने के लिए किया है. तो वन ऑफ द रीजन भी है, और थोड़ी सी ये हमें पता है कि फिजियोलॉजिकल एनीमिया भी इस एज के ग्रुप के अंदर है. तो रेटिस का जो नॉर्मल हो जाना जो है वो ये शो कर रहा है कि जो अभी प्रोबेबली जो है इतना कंटिन्यूस प्रोसेस नहीं है.
Right.
डॉक्टर इरफान कुछ ऐड करना
Conjugate को define कैसे किसी सूरत में भी conjugated in slides conjugated की जनता है ना हाँ तो वो hemolysis तो शायद उसका रुक गया ज़्यादा ही है वो एडवांस पीरियड सर हम वो कंफर्म तो नहीं कह सकते ना कि वो तो जब तक हमारे पास एविडेंस है वो यूज टू लेट दैट एक प्रोसेस से दोनों को इकट्ठा कर पहले हुआ उस वक्त जब उसका एचपी क्या कम हो गया हाँ कम 5 में मेरा ख्याल है कॉन्जुगेटेड की तरफ ज्यादा तवज्जो रखनी चाहिए और बिल्कुल ठीक है बाकी जो रेस्ट ऑफ कंडीशन है दैट कैन बी सो पोजीशन एंड दैट लीड्स टू अनस्टेबल क्लिनिकल स्टेबिलिटी इत्यादि टेकिंग द क्लिनिकली के बाकी जो रेस्ट ऑफ बाकी जो मेटाबॉलिक काजेस जेनेटिक डिसऑर्डर अनस्टेबल so why not neonatal hepatitis PT normal PT the static functions are normal hepatitis में patient stable तो नहीं होगा stable अगर आप infective कहेंगे और दूसरा है कि PT cannot be normal that albumin इसके मतलब है कि synthetic functions of the liver are totally normal जो चीज बाहर पड़ी है वही प्रॉब्लम है वो सेकेंडरी पे ग्रेजुअली एल्ब्यूमिन भी नॉर्मल एल्ब्यूमिन नहीं वो तो अगर लीवर डैमेज होगा फिर ही एल्ब्यूमिन वो सारे जो लीवर के सारे फंक्शन है वो डिरेंज हो जाएंगे बट कॉन्जुगेटेड जॉन्डिस शो
Sir, should we conclude? So should we conclude it, sir? Is there anything else you want to say, sir? And any more suggestions, sir?
Hello.
Yeah, no, not really, not from my side. I think we discussed not all, but almost all aspect of this case. This is a very interesting case, but we have to follow the results which we already sent, and then we will see.
Right, sir. Right. I'll definitely share, sir. I'll definitely keep you people in touch, and I'll definitely share the results when the results arrive, sir.
Okay.
Thank you, sir.
Thank you very much. Thank you.